Here.
Senator Hudson.
Here.
Senator Lewis.
Here.
Senator Nirenberg. Quorum is established.
All right, thank you. I may now make a motion that we move to executive session. Can I get a second? Thank you. I make a motion that we bring Senate Bill 1637 related to communication access services before the body. Can I get a second?
Second.
Thank you. Senate Bill 1637 is before the body. Is there any discussion? All right, thank you. I make a motion that we do pass Senate Bill 1637. Can I get a second?
Second.
Secretary, call the roll.
Senator Lewis.
Aye.
Senator Nicola.
Aye.
Senator Hudson.
Aye.
Senator Carter.
Aye.
Senator Nirenberg. Vote of 4-0.
All right, with your vote of 4-0, that is to pass. Now I make a motion that we bring Senate Bill 899 to before the body. Can I get a second?
Second.
Thank you. I make a motion to bring Senate Bill 899 related to the reporting of abuse and neglect before the body. Can I get a second?
Second.
Senate Bill 899 is before the body. There is a Senate committee substitute ending in .04C. Is there any discussion? Seeing none, we have moved to adopt Senate committee substitute for Senate Bill 899. Can I get a second?
Second.
Thank you. All in favor?
Aye.
Move to do pass Senate committee substitute for Senate Bill 899. Can I get a second?
Second.
Thank you. Secretary, call the roll.
Senator Hudson.
Aye.
Senator Nicola.
Aye.
Senator Lewis.
Aye.
Senator Carter.
Aye.
Senator Nirenberg. Vote of 4-0.
All right. By your vote of 4-0, make that is due pass. Now I make a motion that we exit executive session. Can I get a second?
Second.
All right. Thank you. Now we're going to go into our public hearing time with Senator Berger, Senate Bill 1151. Oh, Rusty, do you need to go first? Okay. We're going to. Perfect. Senate Bill 1536 then with Senator Black. Begin when you're ready, Senator. I didn't see you behind those chairs there. Good morning. It was the tallness of the chair, Senator.
His belly's too big for this table, too. Good morning, Madam Chairman, members of the committee. For the record, my name is Rusty Black, and I represent the 12th Senate District. Thank you for the opportunity to present Senate Bill 1536, known as the Designated Healthcare Decision Maker Act. This legislation aims to establish a clear framework for making healthcare decisions on behalf of incapacitated patients who do not have an appointed guardian or durable power of attorney for health care. Under existing Missouri law, there are gaps in the process for determining who may make critical medical decisions for incapacitated individuals. Senate Bill 1536 seeks to fill these gaps by creating a prioritized list of individuals who may act as designated healthcare decision makers, ensuring that patients receive timely and appropriate medical care while safeguarding their rights and best interests. Key provisions of the bill includes a structured process for determining incapacity and identifying an appropriate decision maker, legal protections for healthcare providers acting in good faith, safeguards against the discriminatory denial of medical care, provisions for addressing disagreements through the probate court system. By enacting this legislation, Missouri will provide much needed clarity for families, healthcare providers, and facilities while ensuring that patients without legal representatives still receive proper medical attention. This bill is similar to a bill I filed last year, Senate Bill 356. One thing before I do my little closing here and ask for questions. Last year we went through negotiations, talking with a lot of people before this hearing and after. And one thing about the people that were involved primarily were people like you and I, elected officials, and then some of the people that represent different agencies throughout our state. This year, I've asked the person that's the reason why I filed this bill to be here, and she's going to present you testimony because I get to hear this at Easter, Christmas, 4th of July, and the pumpkin hayride event, all those kind of things, so we can come up with some kind of solution in our state and not be one of the 5 or 6 that have no solution.
All right, appreciate
Any
it.
questions?
Are there, spoken like the budget chair. Is there any questions for the senator? Senator Lewis?
Good morning, Senator.
Good morning.
I'm excited to hear about your witness because we've had some conversations about this bill. And it looks like, first of all, I totally understand the spirit of your bill. And we talked about this last year. It looks like it's the same language as last year. And we were in talks, and then I don't think it moved anywhere. But I'd really like to, I know we're like one of 4 states that don't do this, so there's plenty of examples. I do have some, my same concerns from last year exist today. So I'd love to continue those conversations with you to see, how we can address some of my concerns.
Okay.
Thanks.
I have has this bill changed from last year?
No.
No?
We filed the same one over again.
Okay.
We have all the records from what went on last year.
Okay. Any other questions for the senator? All right, seeing none. First, testimony in favor. Anyone here to testify in favor? No. Okay. Rusty, would you make sure that the microphone is on for her? Yeah, there you go. That's great.
Hi, I'm a registered nurse from Northwest Missouri. I've worked at a hospital my whole entire career. My name is Lisa, and I have had the pleasure of taking care of some of our sickest patients throughout my career. I've been an ICU nurse for 22 years, and before that, I worked in oncology. Before that, I was a CNA. Today, I want to share with you a long-standing traumatic events that I see families experience much too frequently. I have been firsthand witness to their trauma, desperation, and financial strain that these people will live with for years due to not being a next of kin state. Despite being only 3 months into this year, I have stood witness to devastation of 6 families already that have been living in the financial crisis, in addition to the life-altering situations they find themselves in. I want to share 2 of hundreds of cases that I have witnessed myself. Case 1, 19-year-old male involved in a head-on motor vehicle collision was brought into our hospital, severely injured with major head trauma, multiple facial and body fractures. Intubated upon arrival by the EMS workers, brought into the intensive care unit on a ventilator. His mother and father sat at his bedside through the entirety of his care. 5 days into his care, he remained incapacitated, unable to breathe for himself or make decisions for himself. At this point in healthcare, most of the time we start looking into those next decisions of rehabilitation and how to get them there, which often includes patients receiving tracheostomies and feeding tubes. These next decisions, per Missouri state law, can only be made by a durable power of attorney. In this case, being a 19-year-old, he lacked that DPOA paperwork, which forced his parents to pursue legal guardianship by retaining a lawyer, filling out paperwork, and seeing a judge, for which most takes weeks to accomplish. And it doesn't account for the cost that they incurred from those lawyers as well, in addition to his health care cost. This 19-year-old boy laid in my ICU for an additional 3 weeks waiting on our legal system to grant his parents the opportunity to make the right decisions for him. Case 2, 40-year-old male woke up, get ready to go to work at 4 a.m., leaving his pregnant wife of 8 months and 2-year-old child to continue to sleep. His wife awoke at 7 a.m. She found him lying on their bathroom floor, unresponsive and barely breathing. He had history of asthma. After calling 911, she began CPR on her husband. EMS arrived and brought him to the hospital, where I assumed care of this patient in our ICU. He was ventilated and remained unresponsive. After extensive testing, he was deemed incapacitated for lack of oxygen to the brain, which left him essentially brain dead. Once again, this patient did not have that durable power of attorney paperwork, prompting our case managers to ask his pregnant wife to pursue legal guardianship of her husband so decisions could be made for his crucial outcome. Her response is one that I shall never forget. She looked at our case manager, I was standing next to her, dead in the eye, and said, "I am his wife, the mother of his children, but I legally can't say that he can go to a rehab facility. I guarantee you I will be left with all of his bills." The reality is that every day people are left to advocate for unable to advocate for themselves due to traumatic life events, forcing Missouri's families to seek legal action when they are already balancing a financial burden, mental stress, and horrific circumstances they find themselves in, is a devastating failure in Missouri's law to protect its citizens. It astounds me that a college student can remain on their parents' health insurance. They can be claimed as a dependent by the state of Missouri, but if they become incapacitated, those same parents are unable to make those decisions for them. Denying this next of kin to the right of these decisions is denying these patients the access to timely care that they require, often resulting in poor outcomes. Thank you.
Thank you for your testimony. Any questions for the witness? Senator Lewis?
Thank you so much for your advocacy for your patients and for sharing those stories. My background's in ICU nursing as well, so totally understand what
So
you're
you
saying.
understand,
Yeah,
yes.
thank you.
Any other questions? Seeing none, thank you for your testimony. Make sure you leave your witness form there on the table. All right, thanks. Next in favor?
Madam Chair.
Pull out the chair.
Sorry. Madam Chair, members of the committee, my name is Brent Hemphill. I'm here on behalf of Mosaic Life Care, which is a regional health system based out of St. Joe, Missouri. We've been working on this issue for a couple years now. This is the original bill that was filed, and so through Senator Lewis's engagement, I think we did make some profound changes that moved this bill forward. We would like to reconvene those discussions and hopefully get this bill in a place. I do know there is some questions about having two physicians that are required to come up with the Advanced Healthcare Directive. That makes it very troubling for some of our rural communities to find two physicians. I do know that there is some concerns about a patient on hospice and ensuring feeding tubes and with holding hydration. That can be a huge problem for somebody that's nearing the end of life stage. So we want to make sure that physicians are involved in this determination, but set up the framework for parents, other friends that allow these folks to not just sit in purgatory in our hospitals.
Any questions for the witness? I just want to, so this is caused by gaps in our legal system? Or
Well, no.
Like-
Yes, I mean, so what currently happens is that either you have an advanced healthcare directive that's on file that tells everybody how you want to be dealt with if you become incapacitated, or we have to go to court to get a court injunction, which takes months to get that done. And so you have a patient that literally is sitting there and can't have any remedy to the situation. And
So
we're just trying to create that framework.
Gotcha. I just naturally assumed it would be the, next of kin or a spouse or something that they would defer to. So, I appreciate the conversation. All right. Oh, Senator Lewis?
So, yeah, definitely want to continue the conversations where we left off. And I think, the witness was great with the examples. And I think I don't know if it's like hospital policy varies from hospital to hospital, because in my background, we wouldn't just rely on the next of kin. So I don't know, is there something that maybe hospitals just have different policies or something? Because I don't recall anyone ever, and we've had people on vents and, incapacitated and all that. So I just didn't know,
I'm not sure if there is hospital protocols or if they're physician protocols.
Okay.
And where that disconnect. We just want frameworks to work
For sure.
from. And so
Yeah.
We still want physicians to be able to practice, be involved in this healthcare decision. But we also need family members to be a part of that, or community members, because sometimes, I mean, Mosaic has people who do not have family members or next of kin to make those determinations. And so, as you know from the bill, it could potentially allow somebody from a church, some community, and I know you had questions about what does community mean. We just need to figure that out
Right.
and create a framework.
Okay, sounds good. Thanks.
All right, thank you for your testimony. Next in favor? Fellows? It really does need to move forward, yeah.
Madam Chair, members of the committee, Nikki Strong from Missouri Healthcare Association, here to testify in support as well. We too appreciate last year Senator Black and Senator Lewis working with both of you on some of our concerns. I think Brent did a good job of describing some of the concerns we have, but from a nursing home or long-term care perspective, we have some of the same issues when we have people that come in and don't have someone who is designated to make those decisions for them, and we need the opportunity to be able to do that. So we look forward to making some of the tweaks that we talked about last year and moving forward and getting a framework put in place.
Great, thanks for your testimony. Any questions for the witness? Seeing none, appreciate your time. Next in favor? Anyone here to testify for informational purposes? You're good.
Thank you, Madam Chairwoman and members of the committee. Samuel Lee, with registered lobbyist with Campaign Life Missouri, to testify for informational purposes on Senate Bill 1536. We're grateful for the senator for bringing this bill forward. We had some discussions last year. We're very grateful that he's including protections for vulnerable patients, for those who are disabled, for non-discriminatory language, specifically language in there as well on not denying nutrition and hydration, whether it's naturally offered or artificially provided, whatever it might be. Whether this bill or law is necessary or not, we already have various laws in the state. We have the so-called living will law that passed in 1985. We have the durable power of attorney for health care law, guardianship. That's sort of a decision for you to make. But if you're going to move forward with it, we'd want to ensure that these safeguards are in this legislation. We have some technical questions. It seems in one place it would, page 11, subsection 3 of section 404-1105, it seems to carve out an exception for artificial nutrition or hydration. That's referring to the 1985 living will law. And maybe there's a good reason for that, maybe not. And I would just say also on the last page, section 404-1110, subdivision 2 has language that's very similar, that's elsewhere in statute, that nothing in these sections shall be construed as permitting any affirmative or deliberate act to end a person's life. But then it adds something which is, frankly, to me is confusing and is sort of a circular type of definition or statement, except to permit natural death as provided by these sections that are created here. So is that making an exception? Is this saying, well, yeah, but natural death as we define in here, or what that is? I just find that confusing, and I'm concerned that a court of law or hospital lawyers might find that confusing down the road. But we're just very grateful that Senator has brought this forth again for this discussion.
I appreciate your testimony. I'm sure others do as well. Any questions for the witness? Seeing none. Thank you, Sam. Anyone else here to testify for informational purposes? Good morning.
Good morning. Thank you, Madam Chair. Members of the committee, for the record, Susan Klein representing Missouri Right to Life, here to go on record for information only, and pretty much the same reasons as Mr. Lee just spoke about. We've worked on this legislation for many, many years. We thank Senator Black for bringing it forward. I think it is time, that this issue is dealt with. Obviously, the issues that we were looking at as we were working on it in many years past was the issue of hydration and nutrition and the list of decision makers. So we have some of the same concerns, so we're willing to work with the senator on those as well, and appreciate you all for bringing this forward and for dealing with it.
Thank you. Any questions for the witness? Seeing none, appreciate your time. Thank you. Anyone else here to testify for informational purposes? All right, going, gone. Anyone here to testify in opposition? All right, Senator Black, any closing comments?
Thank you very much.
Appreciate your
We'll work on seeing if we can get something done,
Right.
finally get this out of the way.
All right, thanks. All right, we'll go to Senate Bill 1151 with Senator Berger next. Senator, begin when you're ready. Go ahead.
Good morning, Madam Chair, members of the committee. For the records, representing the 27th District, Jamie Berger. Thank you for the opportunity to present Senate Bill 1151 dealing with hospital institutionalization, if I can even say the word. Hospital institutionalization is not a new problem, and multiple agencies have been working for years to try and solve this problem, but to no avail. Children and adults with developmental disabilities, serious mental illness, or substance abuse disorders are being left in hospitals long after the medical condition that caused them to be admitted is resolved. Abandoning children and adults in hospitals is harmful to them and costly to the hospital as well as the state. This bill allows the hospital to notify the juvenile court when a child no longer requires hospitalization. The court would be required to take custody of the child. In cases of adults with developmental disabilities, severe mental illness, or substance abuse disorder, the hospital would notify the Department of Mental Health, and that department would be required to provide treatment. This bill would require the state to reimburse the hospital for costs incurred after the state was notified that hospitalization is no longer required. I do understand that it has a large fiscal note. However, I believe it is something that the hospitals would like to work with the Department of Mental Health on in upcoming years. Children and adults with developmental disabilities, serious mental illnesses, or substance abuse disorders are often housed in hospitals long after their medical condition that caused them to be admitted is resolved. Thank you, Madam Chair, and welcome to any questions.
Yeah, just a quick question, Senator. I was wondering how our public administrators, have they weighed in on this at all?
If they have, they haven't talked to me.
Okay, great, thanks. Any questions for the witness, or for the senator?
Yeah,
Go
Madam
ahead.
Chair, thank you. Good morning, Senator.
Good morning.
Appreciate your comments, obviously understanding that there is a large fiscal note, but I do think there are some things that we can do to address that. Looking at page 2 there on line 36, and, possibility, maybe remove that language that says whichever is greater language and limit it just to those full. Oh, I'm sorry. There we go. Let me try that one more time. I appreciate your acknowledgement that this does, as written right now, would possibly have a large fiscal note. And so I do think there's some things that we could do to rein that in. Looking at page 2, line 36, possibly removing that whichever is greater language and limit it just to the full allowable cost under HealthNet, I think would be a good step. But again, something I'd like to work with you on. I think this is a good piece of legislation.
For sure, I think this opens up conversation, and I think that's what the idea of the bill is.
Okay, thanks, Senator.
Thank you.
Any other questions for the senator? Seeing none, thank you, Senator. Next, we'll hear witnesses in favor. Anyone here to testify in favor?
Good morning. Thank you to Madam Chairwoman and the members of the committee. I am representing a major health system in the state of Missouri, Mercy Health System, and I'm the lead administrator for behavioral health for the health system. This is an issue that has been ongoing for several years, and just to put in perspective, we operate roughly 260 inpatient beds at 7 locations across the state of Missouri, and those inpatient beds are always at capacity. We are often holding 25 to 50 people in our emergency departments for psychiatric admission, sometimes for days. In the last 18 months, we have had the equivalent of 2,687 days where we have been boarding patients in our emergency departments. So that equates to over 7 years of bed capacity that we're losing, and about 567 patients that we've not been able to serve. So it's a very complex issue. We work very closely with the Department of Mental Health and Children's Division to try to remedy the placement issues. But hospitals were really never built to hold patients and house people beyond medical necessity, and we have essentially become the de facto place where people stay when there's no place for them to go. So that has a domino effect out to our emergency departments, and again, not just on the behavioral health side, but on the medical side, where we're taking up, a portion of medical ED rooms and unable to serve those patients. I just want to highlight some case examples, and to the senator's point, the deterioration that we see with people that are being housed in locked psychiatric units that don't need to be there, children who are missing school, children and adults who don't get to go outside, sometimes for months or over a year, because they're being housed in a locked psychiatric facility. And it is not only not therapeutic, it really is counter to their well-being and their development. But it is the situation that we're left in because there is no alternative. So we are really at a very constrained point. The cost for those 18 months, well over $800,000 in cost for those patients that we're holding in that short period of time. So it makes delivering behavioral health services, the proposition of sustainability and our ability to continue to serve our communities becomes very challenging. I think that I'll end with those comments.
I appreciate your testimony. I know that it's been, when you spend time, I've spent quite a bit of time in my community, it does seem like it doesn't matter if it's the homeless or, whatever it is, it seems like the hospitals are becoming the place where, by de facto, when people don't know what to do with somebody, they take them to the hospital. So I appreciate your testimony. Any questions for the witness? Seeing none. All right, appreciate your testimony. Anyone else here to testify in favor?
Good morning. My name is Lynn Rasnick, and I'm here for this bill from the Missouri Hospital Association. So, child and adolescent hospital utilization for behavioral health conditions remain elevated compared to pre-pandemic norms. Between 2016 and 2024, hospital emergency department visits for any behavioral or mental health conditions have increased by 35%. Visits for anxiety have increased 65%, and visits for suicide risk or self-harm has increased 146%. While ED visits by children in Missouri with a principal diagnosis of suicide attempt or ideation have increased by 252%. Hospital visits by children under the age of 20 in Missouri with a principal diagnosis of suicide attempt, ideation, or self-harm are growing more quickly for the younger children. During the same time frame, ED visits increased by 267% for children ages 5 to 9, 163% for children ages 10 to 14, and 55% for teens ages 14 to 19. I have to say I've been a registered nurse for almost 40 years. My background is maternal child nursing, and while I've delivered babies and taken care of children in the ED with trauma, ATV accidents, all those kind of things, I was not a psychiatric nurse. But anymore, every nurse in the ED is a psychiatric nurse. As tragic as these statistics sound, for those children that have attempted the unthinkable act of self-harm or suicide, attempted suicide, those children are appropriate for inpatient care and treatment if they can find a bed. And so finding a bed is another hearing for another day. But for those children that do not meet inpatient care and treatment, they then border in the emergency department until placement is found. So when a patient comes to a hospital, there are certain regulations that have to be met, and one of those is a safe discharge plan. And for these children, there is not a safe discharge plan. You can't just discharge a 9-year-old into the street. Long-term placement is an issue because the parent or guardian is either unable or unwilling to take that child back home. There may be other children in the home that are at risk if those children go home. And so, as we just heard, they may then get what you would say is abandoned in the ED. So, these children have long histories with the Department of Mental Health, the Division of Children's Services, and Juvenile Court. They may have experienced multiple placement across the state or even been placed in bordering states far from their homes. Again, hospitals are mandated to secure a safe discharge plan before the minor child can be discharged. But when that cannot be met, the child is bordering in the ED in a small psychiatric preferred room, no stimulation, no windows, no peer contact, and no education. These children border in the ED. They may have a safety sitter, which has to be absorbed by the facility that's taking care of them. It's not reimbursable, can't charge for it. The environment around them in the emergency department is chaotic. Heart attacks, strokes, traumas are coming in, and more than likely there's an adult psychiatric patient next door who is violent and disruptive, and so then they're then exposed to that. It's not unusual for a child, especially a child with a developmental disability, serious mental illness, or substance use disorder, to stay in the ED for weeks, months, and in extreme cases, up to 2 years. And when I say 2 years, I mean 2 years. That's not one case, that's multiple cases across Missouri at any one time. Hospitals have to hire tutors to come in and teach these children. It's a very strenuous time. While the ED staff try to be creative by keeping consistent staff so the patient has somewhat of a routine and caregiver message is consistent to prevent outbursts, long-term border children also put a strain on the staff who feel helpless when unable to help the child's situation. Workplace violence frequently erupts with these children due to frustration, which only exacerbates placement issue. The number of children bordering in ED is growing by nearly 15,000 hours per year at the cost of over $1 million per year to the hospital facility. They don't get that reimbursement back.
Oh, sorry, I didn't want to interrupt. Is that the end of your testimony?
That's the end. Thank you.
If you wouldn't mind, would you be willing to share a copy of your testimony with
Yes,
the committee?
ma'am.
Thank
Yes,
you. Yeah, if you
absolutely.
would just leave it there or help us work it out, we'll get a copy and we'll distribute that among the committee members. I appreciated a lot of the statistics that were in your testimony, so appreciate that. Any other questions? Yeah, very good. Any other questions for the witness? Seeing none, thank you again for your testimony. Blake will make sure we get a copy of that.
Yeah.
Yes.
If you just leave it up there, I'll make sure everybody gets a copy. Thank you.
It's okay. Next in favor?
Thank you, Madam Chair, members of the committee. Justin Alferman, registered lobbyist for SSM Health. We'd like to go on record in favor of Senate Bill 1151. We want to thank the senator for filing this bill and the committee for hearing it. I've been at SSM for almost 7 years now, and this has been an issue that has been top priority for us year after year after year. The problem isn't getting better. In fact, I think it's getting worse. I want to thank you, Senator, for talking about the fiscal note, because that fiscal note is real. Whether that's paid by the state, doesn't matter, because hospitals are going to incur that cost. We are already currently incurring that cost. But even beside the cost, like, these patients are not getting the appropriate care that they need because they are oftentimes languishing in EDs that is not appropriate care for these type of patients. So there's many issues that we need to address in the state. This is a step forward in talking and having that conversation and making sure that legislators are aware of it, but we're going to continue providing health care the best that we can. But we've got to do a better job in this state of finding placement for these patients because the ED is not the appropriate place for them, but we're not going to discharge them without an appropriate place for these patients to go. So we have a lot of work to do. SSM would like to be a part of that conversation with you all. So we're here, we're ready to roll up our sleeves and get ready to work.
I would appreciate being able to work on this in interim a little bit more and see what we might be able to do long term. I would also
Absolutely.
be interested in knowing how many of these patients are return patients.
A lot of them. A lot of them. Unfortunately, we see this in the St. Louis area where if we do find an opportunity for placement, that they will return and they will kind of do something like switch systems. So like maybe they come to us, they find placement for a little bit, that doesn't work out, then they go to an ED of a different system. There's 4 or 5 different healthcare systems in the St. Louis area, and sometimes we just see a revolving door where they go to one system, they go to another system, and unfortunately, that happens quite often.
Yeah, if you have statistics in regards to some of that,
Absolutely.
I would appreciate it. And I'm sure the committee members would also appreciate it. Thank you for your testimony. Yes.
And really just a comment, but I am with you in terms of diving into this situation deeper in the interim as well. I think, we've heard this for a very long time. I mean, I remember talking with our director of health and talking to Val and her sharing that, we're 1/100th of where we need to be in terms of pediatric, psychiatric beds in the state of Missouri. And you have to have tremendous resources to be able to access those care outside of the state, quite frankly, because you can't receive it inside the state. So you're looking at going to Marillac if you're in Kansas City, for example. You're looking at going to Boys Town in Omaha. You are looking at getting your kid care wherever you can. And unfortunately, what happens when people don't have those resources, these kids are getting very, very sick in these hospital situations. And there's something we have to do. So yes, looking at what and not to sound callous, but right now people are looking at fiscal notes and saying, hey, we can't do this because it's going to cost the state too much. The system's going to incur those costs one way or another, and it's going to pass on to all of us. So we have to do a better job of getting these kids out of those situations sooner, get them healthier sooner, because then that helps them lifelong, right? Deal with these chronic conditions, quite frankly. So thank you. And again, this is something that I think that we really can come together and work to address some of this. Obviously, we're a long way from being where we need to go, but I do think there's some important steps we can take that would make real change.
Yeah, and we can have more of these internal conversations, just not to tie up everybody's
Yep.
time. But I do think we've made progress with the bill that we passed in the Senate that was, the Charity Act, where we're talking with communities, DSS, some of these where it's more interconnected, and so there's more crossover and reporting and things like that. So I'd love to continue to have the conversation. Anyway, thank you for your testimony.
Thank you.
Next in favor? Okay, gone. Next, we'll go to those who are here for informational purposes. Anyone here for informational purposes? Anyone here for in opposition? All right, Senator, any comments?
Thank you, Madam Chair and Committee.
All right, appreciate your time. All right, thank you. That wraps up the hearing for Senate Bill 1151. We will now move to House Committee's substitute for House Bills 1667, 2294. Are you, come up, whoever's next. We're going to limit testimony to 2 minutes after our House sponsors speak. So 2 minutes. Oh, we did slide it up a little bit. I hope that helps. Representative Seitz, begin when you're ready.
Absolutely. Thank you, Madam Chair. For the record, I am State Representative Brian Seitz. I bring to you the House Committee substitute for House Bills 1667 and 2294, the Born Alive Abortion Survivors Protection Act. This is a protection bill for infants outside the womb, those who survived an abortive attempt. The main focus is found on page 1, lines 4 through 6, and lines 10 through 12, which state, A child born alive during or after an abortion or an attempted abortion shall have all the rights, privileges, and immunities available to other persons, citizens, and residents of the state, including any other live-born child. The healthcare providers should exercise the same degree of professional skill, care, and diligence to preserve the life and health of the child as a reasonably diligent and conscientious healthcare provider would render to any other born alive child of the same gestational age. In 2024, the American Journal of Obstetrics and Gynecology analyzed 13,777 late-term abortions between 15 and 29 weeks performed in Canada and found that 11% resulted in live births. Because of gaps in national and state reporting, the number of babies born alive in the United States is unknown. During a recent survey in which 8 states responded, available data shows that 284 babies were reported born alive, having survived an abortive attempt between 1997 and 2024. The Canadian Institute for Health Information showed at least 1,155 babies were born alive during late-term abortions between 2013 and 2014 and 2021 and 2022. The very definition of late-term abortion is imprecise and shifting. The gestational age at which an unborn child can survive outside the womb with medical support is decreasing, with babies surviving at 22 weeks gestation and slightly earlier. Data from the Centers for Disease Control and Prevention indicates that roughly 1% of all U.S. abortions are carried out at or after 21 weeks gestation, as many as 10,000 late-term abortions per year. The true total may be even higher because several states that allow abortion through all 9 months of pregnancy do not share data with the CDC. Federal law states that all infants who are born alive following an abortion are full persons under the law. However, the federal law does not ensure that these infants are given proper health care, hence House bills that you have before you today. This legislation considers the infant to be like any other person born alive. They should receive care consistent to those of the same gestational age. The intrinsic value of human beings of all abilities is a key American ideal enshrined into law in the Americans with Disabilities Act, and babies who survive abortions are just as much a part of the human family. Madam Chair, esteemed committee, this bill only concerns abortion in that that is what was attempted to end the precious life. No one can deny that a baby born alive is a human being, a miracle of creation, a person of dignity, unique in the universe. If the infant fought that hard to live, let's give them a chance. Psalm 127:3 states, "Lo, children are a heritage of the Lord, and the fruit of the womb is his reward." I'll turn this over to my fellow sponsor.
Good morning, Madam Chair, members of the committee. For the record, Representative Holly Jones, representing the 88th House District in Missouri. There's not much I can add to that, but I'd like to try, if I may. Once a child is born alive, the question of choice is over. The child exists. The child is a patient, and in every other circumstance, our laws, our medical ethics, and our basic normal instincts demand that we protect that life. From a medical standpoint, the standard of care is clear. Physicians are trained and ethically obligated to provide treatment to any newborn showing signs of life, whether that's breathing, heartbeat, or pulsation of the umbilical cord. These are not political criteria, they're clinical facts. When a baby meets them, that baby's alive, and when a baby is alive, medical professionals have a duty to act. From a legal standpoint, our nation has long recognized that a child born alive is a person under the law. That principle does not change based on the circumstances of birth. It does not change based on intent. It does not change based on politics. A newborn child is a person, and persons are entitled to protection. And third, from a moral standpoint, this is one of the clearest issues we'll ever face. We're not being asked to weigh competing rights. We're not being asked to judge motives. We're being asked whether a newborn infant already separated from the mother's body should be left without care. I refuse to believe that indifference is an option in a civilized society. Some argue that these cases are rare, and I think that Representative Seitz has outlined some things indicating through studies and numbers that these cases aren't as rare as we would like to believe. We're happy to take any questions. We could go on and on about this, but I believe that, and I think Representative Seitz would agree with me, that children separated from the mother's body, born alive, deserve the same protections, and whether that's palliative care to an understanding that the child may pass anyway, that we provide whatever we can as a comfort measure. So we'll take any questions. Thank you, Madam Chair, members of the committee.
Thank you. Just a couple comments. I really appreciate you bringing this forward. I carried this last year. It's a really critical piece of legislation, I believe. And like you said, indicated in a civil society, we talk about animal rights, and we would never want to. I live on a farm, and there's loss of life all the time, babies, calves, things like that, and it's always a tragedy. But to think that an infant born alive does not have equal access to the rights of any other human being is just undignified of a civilized culture. So anyway, thank you for bringing this forward. Anyone have any questions for the witnesses? All right, seeing none. First witness in testimony in favor, limiting it to 2 minutes.
Thank you, Madam Chair, members of the committee. For the record, Susan Klein, representing Missouri Right to Life, here to go on record in support of House Bill 1667 and 2294. And we thank Representative Seitz and Representative Jones for bringing this important legislation forward. It's life-saving legislation. It really came to light several years ago whenever Virginia and New York that was in the news, actually some doctors laying a baby aside and saying, we need to talk to the mom and see where we are, rather than immediately giving those babies care. And they were born alive, they were laying on a table, they are separate from their mom, and that's not the time to discuss whether that baby deserves care or not. That baby deserves care immediately. As Representative Seitz stated, this is really just it's not about abortion. It's about a baby that is born alive after an abortion attempt. Recently, Melissa Oden was in the Capitol. She spoke. She has the Abortion Survivors Network. The babies born out of abortion, and born alive after an abortion attempt is growing, and they have stories to tell about how and whether they got care and at what point they got care. So Missouri law does not clarify on this kind of a birth. And I think it's time that we step forward and we make sure that these babies are getting the care that they deserve.
I agree. Thank you. Anyone have any questions for the witness? Seeing none, appreciate your time and your testimony.
Thank you.
Next in favor?
Thank you, Madam Chairwoman, members of the committee. Samuel Lee, registered lobbyist with Campaign Life Missouri, to go on record wholeheartedly in support of House Committee Substitute House Bill 1667 and 2294, and very grateful for our sponsors and all those in the House who sent this over here, and this committee, and Senator Yu and Senator Bratton who've sponsored this over here. We imagine these types of circumstances occurring in a hospital or a clinic or an abortion facility, but these also occur in someone's home or in some place. There are stories, unfortunately, of evil boyfriends and pimps who provide abortion pills to women late in pregnancy, causing abortions, and these babies are being born alive and are not getting the care that they need to. If a nurse or a healthcare provider happened to be present at that time, they'd be obligated to take care of that child and to make sure that that child is immediately transferred to a hospital like any other child who would be born outside of that abortion situation. But the bill also provides civil penalties where if you have these types of circumstances where someone unlawfully would induce a late-term abortion and that baby is born alive and would kill that child or would harm the mother of that child, even causing the death of that child. I don't want to lose sight that these provisions are in these bills to protect these people, the mother and the child, in these horrible situations that unfortunately do occur because of the prevalence of mail order and easily accessible abortion pills. Happy to answer any questions.
Thank you very much then for your testimony. Any questions for the witness? Seeing none. Appreciate your time. Make sure you leave your witness for. Very
Did
good.
it online.
Very good. Thank you. Next in favor?
Good morning. I'm Timothy Faber with Issachar LLC. In America's past, there were those that were considered less than human, and they were not given rights. Someone could kill them if they wanted to. About 90 years ago, in the nation of Germany, there were those who were considered less than human and were killed by the millions. And the Romans, though they claimed to be civilized, were the most barbaric of all. Because in the Roman society, if a child was born and it was unwanted for whatever reason, they would simply take it to the dump and allow it to die by exposure to the heat and the cold and the rain. But now here we are in 21st century America, where many consider babies to be less than human, deprived of personhood, and regulated to be nothing more than a clump of cells, deprived of their inalienable right to life and liberty. Some would go so far as to say that babies are vermin, posing a health risk to their own mothers. And tragically, they are often seen as not being financially viable. There are children dying not because of their race or ethnic heritage, but simply because of their age and the fact that they are unwanted by their parents. And though a child may be unwanted by its mother or its father, it is not an unwanted child. There are over 2 million families in the United States today who would love to adopt a child. Finally, let me ask you a simple question. If we can allow an infant who just survived an attempt to kill it to die, then will it be okay to allow a 6-month-old baby to die if we don't want it? Or what about a 2-year-old? They can be pretty challenging, you know. What about a 13-year-old? What parent of a teenager hasn't thought that from time to time? Or what about an old man sitting before you this morning? If I was unwanted, would it be okay to kill me?
Thank you for your testimony. Appreciate it. Any questions for the witness? Seeing none. Again, thank you for your time. Next in favor?
Good morning, Madam Chair, members of the committee. I'm Dr. Guillermo Villatrueva for the Missouri Catholic Conference, and we would like to go on the record in support of the House Committee substitute for House Bills 1667 and 2294, and thank the sponsor for bringing these bills forward. This should go without saying, but no newborn should be left to suffer or die without medical care. Current law prohibits the intentional killing of a child born alive after an attempted abortion. However, it is less clear whether penalties apply when such a child dies due to recklessness or negligence, such as failing to provide proper medical care. And this bill would clarify the issue. I mean, while there is limited data on how many children survive abortions, we know that such cases do occur. I will not go into the statistics because Representative Seitz has already mentioned them, but we urge you to pass this bill to ensure that every child is given the same medical care, grounded in his or her basic right and equal God-given dignity. In doing so, we will take a meaningful step toward what Pope John Paul II called a civilization of life and love. Thank you, and if you have any questions for me, I'll be glad to take them.
I appreciate your testimony. You know, just ironically, we just got done hearing Senate Bill 1151, where we're talking about taking care of teenagers and kids, youth who need hospital care and treatment, and how appalled we are that there's this gap in the system for these kids. And so, again, just a timely reminder of the importance of this as well. Thank you. Any questions for the witness? Senator?
Good morning.
Morning.
I'm glad that Madam Chair brought that up because I was thinking the same thing. You're here to testify on behalf of children or, in the sanctity of life. I'm just curious why you didn't provide testimony on the previous bill about, the kids with mental health staying in hospital beds and, we're trying to get them the appropriate level of care.
Oh, it's a very technical bill, so we support it in principle, but we're looking at the details. But yeah, we don't have any objections to those bills. Yeah.
I just think it's interesting, just the level of consistency. Do you not care about kids that are?
Let's
suffering?
not badger
Okay.
the witness.
Okay. All right.
Thank you. He
Thanks.
came to testify in favor of one piece of legislation, maybe not knowing that there's other pieces of legislation that we're hearing. Thank you. Thank you for your time. Any other questions for the witness? Seeing none, appreciate your testimony. Next, in favor?
My name is Bev Allen, registered lobbyist for Liberty Link, Missouri. Just want to go on record in favor of this bill. I have nothing more to say. Just took me longer to get up here than it is for me to say anything, because there's nothing to add. Well, there is. As time goes on and technology goes on and medical care gets better and better, it only stands to reason that we need to do everything we can for every person born and unborn. Thank you.
Thank you. Next, in favor? Any questions for the witness? Thank you, Beth. Next, in favor? Okay, going. Anyone here to testify in opposition?
Madam Chairperson and members of the committee, thank you for the opportunity to speak. My name is Dr. Rachel Crabessa, and I'm a physician in obstetrics and gynecology in St. Louis, Missouri. I've spent my education and career working to improve the health of women and their families during the most joyous and the most heartbreaking times of their lives. I'm here today to speak in opposition of these bills, as the provisions limit a physician's ability to deliver high-quality, evidence-based, and compassionate care. No woman anticipates the decision of terminating a wanted pregnancy. Approximately 2 to 5% of pregnancies every year are affected by birth defects. In one condition called renal agenesis, infants do not develop kidneys and therefore also do not develop functional lungs. If the baby survives to delivery, there is no medical intervention that can save them. It is 100% fatal. In this circumstance, patients may choose to utilize neonatal palliative care. This means that instead of choosing invasive interventions like putting the baby on a ventilator and attempting to save their life, they're allowed to pass peacefully with their family by their side. Part of my concern with this legislation at hand today is that it threatens this type of care by requiring the use of life-sustaining interventions like a ventilator. I worry that the additional and unnecessary suffering that may be brought to my patients and their families in situations where the baby's life cannot be saved. Criminalization of abortion care has consequences far beyond abortion. Abortion care is inseparable from the care that we deliver for ectopic pregnancies, miscarriage, and stillbirth. The most well-written and well-intentioned law with dozens of exceptions could not possibly cover the complexity and nuance required for caring for every single pregnancy of every pregnant woman. The language in this bill interferes with a physician's ability to offer family-centered, compassionate options for families. Though it's intended to create exceptions for life-threatening circumstances, the possibility of criminal lawsuit frightens providers into withholding appropriate care even when it fits the confines of these exceptions. The creation of limitations causes dangerous confusion amongst doctors. When the legality of care is uncertain.
Thank you for your testimony. Anyone
questions?
Here have any questions? Yep. Go ahead, Senator.
Thank you, Doctor, for being with us, and I really appreciate what you said, and again, leaving very complicated decisions with families and their providers. And I think that you raised a lot of the issues that are so complex that many of us can't even fathom. But again, all of these have tremendous, especially not just complexity, but the nuance. And an understanding that unfortunately there are these situations where you know that baby is not going to survive, and to provide that family with that peace and the dignity that they deserve, instead of having that baby ripped away from them, to provide life-saving interventions that aren't going to work.
Yes, thank you.
And so At the end, you were finishing up some comments. Was there anything else that you would like the committee to know? And I'd also ask if you could provide, make sure that we have a copy of your testimony. I think that you, I really appreciate your, again, expertise in this issue.
Yes, ma'am. What I was just going to say is that whenever the laws are vague, it sometimes leads to very dangerous delays in care because physicians should not have to worry about whether or not providing the life-saving care could result in them being imprisoned.
Thank you.
Go ahead, Senator Lewis.
Good morning. I just wanted to say that, I think that, I think both sides aren't going to agree on this issue, but I think that we come together a lot with trying to address increased access to health care. And the OBGYN lobby day, I don't know if you participated in that.
Yes, ma'am.
They were here a couple weeks ago. And I remember visiting with some residents and some people, and some OBGYNs who finished their training. And some of the residents and students were talking about that because of some of the laws here in Missouri, they are not even thinking about practicing here in Missouri. So, while we try to increase access to health care, we've got hospitals closing, I think that your point of tying the hands of our healthcare providers, not being able to provide care, is a ripple effect of getting our providers fleeing the state. So just wanted to, I guess, elaborate on the discussions I had during the lobby day with your colleagues.
Yes, ma'am. That is true. In OBGYN residencies that are in abortion restrictive states, there was a 6% decrease in residency applications to those programs in the year 2024, I believe. Residents are most likely to practice within 300 miles of the place where they completed training. And so when residents are dissuaded from training in places where they're worried about their scope of practice, they are unlikely to practice in those places. And so it really puts rural communities and historically conservative communities at risk of being without care. You can particularly see in Idaho where I don't remember the percentage, but a very large percentage of OBGYNs have left the state as a result of the restrictions on care, and it is making being pregnant in those states very dangerous. Thank you.
Okay, that's all. Thank you. Next in opposition.
Chairwoman, members of the committee, thank you for the opportunity to speak today. My name is Dr. Sarah Combs. I'm an obstetrician and gynecologist in Missouri. I've spent my education and career steadfastly caring for the women and families of our state. I'm here to speak today in opposition of this bill. I speak against the criminalization of OBGYN physicians and patients that this bill proposes. No woman desires a circumstance in which this bill may apply to her, but every pregnant woman takes the risk that an often highly desired pregnancy can take an unlikely and heartbreaking turn, leaving her vulnerable to criminalization by this bill. Take, for example, cervical insufficiency. This is a condition in which a woman's cervix, the bottom of the womb that typically holds in a pregnancy, dilates too early. This can happen at 18 weeks, 20 weeks, 22 weeks, 24 weeks, virtually any gestational age. This typically happens painlessly without the pregnant woman realizing she's in labor until she is completely dilated and ready to push. This can happen in the hospital, but more likely this happens at home. With no cervix between the baby and the outside world, a very, very premature baby can deliver at home, removed from the specialized interventions of a hospital that may or may not be able to offer care. Even if a baby this young was placed in the care of a capable neonatologist within seconds, it may not survive the first hour of life. As you can imagine, a loss at home like this is terrifying and traumatic for everyone involved, the mother, father, any siblings who happen to walk in on the mom bleeding and scared with a tiny infant in her arms. If this bill is passed, what would you advise the mother to do? Should she come into the hospital with her past baby and be relentlessly questioned, scolded, or worse, held liable for a self-induced abortion, threat of legal persecution and imprisonment? This is not unrealistic. Despite the well-intentioned nature of legislation intended to protect women and children in Missouri, there is no law that can comment on every circumstance advance every pregnancy and every decision that a woman has to make on behalf of her body. For this reason, I strongly oppose any legislation criminalizing physicians or pregnant women. The language in this bill not only poses risk to physicians, it poses risk to the same vulnerable constituents it seeks to protect. But you could do better for the people of our state. I am here begging you to listen to the people who understand science and who understand the humanity of these decisions. Access to abortion care and reproductive rights affects more than abortion.
Thank you for your testimony. Any questions for the witness? Seeing none? All right, thank you.
Thank you.
Next in opposition.
Chairwoman and members of the committee, thank you for the opportunity to speak today. My name is Brittany. I'm an obstetrician and gynecologist living in St. Louis, Missouri. I've devoted my education and life to caring for the women, babies, and families in our state, and I'm here today to speak in opposition of HB1667, specifically against the criminalization of medications and procedures that can be used in miscarriage and early pregnancy care. One of the best parts about my job is telling a patient who's been trying to get pregnant for years that she's finally pregnant. You can imagine the expressions of joy and relief on her face when she sees the ultrasound screen with the pregnancy inside her womb. Unfortunately, it's also my job to tell that same patient when she has lost her pregnancy and there's no longer a heartbeat. This happens far too often, as up to 10 to 20% of all pregnancies will end in miscarriage. Whether you know it or not, every person in this room today knows someone who has been in this scenario. Just this past week, on 2 separate occasions, I've held the hands of a patient and her husband as they both cried when I told them they lost their pregnancy, grieving over what could have been. Miscarriage care can be complex, both medically and emotionally. When a pregnancy fails, many women will pass the pregnancy on their own, but this can take up to 8 weeks, a period of time that is painful, unpredictable, and traumatizing, especially for women desperately wanting to grow their families. In these cases, many patients opt for medications or a procedure to help them pass the pregnancy on their own terms, preserving their freedom to engage in the medical care that best fits the needs of their family. Often, these same interventions can be used in an abortion. Criminalizing the use of any instrument, device, medicine, drug, or any other means or substance to undergo an abortion will impact far more than just abortion. This will cause direct harm to women undergoing miscarriage management and early pregnancy loss. These medications are safe, effective, and have fewer side effects than over-the-counter medications like Tylenol and Advil. You claim this bill is supposed to protect babies and help families grow. Although written with this intention, HB1667 will directly prevent it. The language in this bill will also limit the fundamental freedoms of Missourians to have agency and autonomy in the medical care they receive at their most vulnerable moments. No one wants to be told they're going to have a miscarriage. Don't also take away their right to choose what happens next. I ask that you oppose HB1667. Thank you.
Any questions for the witness? All right, seeing none, thank you. Next in opposition.
Good morning, Madam Chair and committee. My name is Emma Zyrick Rhodes, and I am a chaplain, a pastor's wife, and a grateful recipient of abortion care who is honored to speak in opposition to HB 1667 and 2294. In my Christian tradition, Romans 12:15 teaches me to weep with those who weep. Weep with particularity and humility, not to generalize or misrepresent their grief. Amid complex and often heartbreaking healthcare decisions, the choices of families should be guided by dignity rather than one-size-fits-all legislation. As a faithful Christian, I affirm the desire to protect Missouri families. But even well-intentioned policies must be judged by their impact, and this legislation will cause harm, misrepresenting abortion care, threatening physicians who attempt to act with integrity, and applying a rigid approach to deeply complex reproductive circumstances. I urge you to reject this bill and uphold the dignity, mercy, and humility that my faith demands from Missouri families. Thank you.
Any questions for the witness? Seeing none, thank you. Next in opposition.
Thank you, Madam Chairman and everyone present. My name is Rachel Kroll. I'm from Columbia, Missouri, and the reason I'm in opposition to this is to echo a couple of OBGYNs who have just talked about this. So I have a rare genetic illness that has a 75% maternal death rate. My husband and I chose to get pregnant anyway. Our pregnancy lasted 25.5 weeks. I had incredible care, and he's going to be 29 on his birthday. There were many emotional decisions during my pregnancy, and my OBGYN, who is a resident when he delivered me, and my gynecologist growing up, and then delivered my son.
I don't want to interrupt you, but would you just speak into the microphone so
I'm
that
sorry.
we're sure
Sure.
everybody can hear? Thank
Sorry.
you.
Oh, yeah, that's a lot better. So there were many times where my OBGYN, who, to understand medical care, an OBGYN has one patient, and that is the woman. When my pregnancy was able to achieve 12 weeks, the head of the neonatal intensive care unit and the pediatrician I chose to start meeting with my OBGYN. But throughout my pregnancy, it was my choices that I had to make. And one of my big concerns with this is that this law does not reflect real healthcare. Like the ICD-10 code for an abortion is the exact same as for DNC. And a lot of times, even a successful pregnancy requires a DNC after in order for the woman to survive. But just as I made decisions along my 25-and-a-half-week pregnancy to continue it, my husband and I had already gotten counseling and genetic counseling. And so,
Thank you for your
but
testimony.
another woman who doesn't have that same information, who wasn't diagnosed when they were 7, who goes
you for
into
your
it
testimony.
not knowing, doesn't have
Are there
those.
any questions for the witness? Yes.
I know we've got a lot of folks here to testify and certainly want to hear from everyone,
Sure.
but do you want to just take a few more seconds to wrap up what you were going to say?
Yeah, I was just going to say, the decisions my husband and I and my doctor made during those 25-and-a-half weeks were ones that were mine to make, just like any woman, because most women with my illness are diagnosed in autopsy. And I'm the first woman in my family to have a child. So when you have an illness where the 75% maternal death rate, if you don't know until you're pregnant that you have it, then you have to make tough calls. And if your doctor is afraid of being arrested for giving you the care that they need, the unbiased care of being your provider, then that puts women at risk, and it puts our whole society at risk. Thank you.
Any other questions for the witness? Great. Zena? Next in opposition?
Good morning, everyone. My name is Marta Weiss. I live outside of Columbia, Missouri. And I am here to oppose this tricky abortion ban, HB 1667, and demand that you respect the will of the people. These types of bills are just a small piece of the larger anti-abortion strategy to make abortion illegal and unavailable in all cases. And as we have seen from other people talking, there is such a variety in what can happen in the pregnancy. Pregnancy is one of the most dangerous things that a woman has ever done in her life. And many people do it over and over, and they have perfect pregnancies, but that's not always the case. Abortion is safe, legal. Abortion is popular. Not because a woman, I don't feel like having a pregnancy now. No. There's so many consequences. It's very individualized. Missourians already voted to kick politicians and government out of personal medical decision-making when a majority of us voted to legalize abortion and establish a right to reproductive freedom. Missourians already said no to abortion bans. No means no. Thank you.
I just have a quick question. Do you think that means that clarifying the law should not go before the people ever again? That once somebody votes on something, or you never pick up the issue again and never discuss it any further. So when you say no means no, my question is, there's a lot of concern and questions as to some of the legality and some of the clarification of the law that was passed. So to send it back to the people is not, it's an opportunity for you to weigh in again, is it not?
It is, but if
So-
people,
so
but if
where-
the majority
where are
of
we cutting
people,
where are we cutting people out?
not cutting people out, if there are people that do not believe in abortion, then don't have an abortion. It's a matter of choice. And that's what people want, is choice. And if someone doesn't believe in abortion, I respect that. So don't have an abortion.
So you will appreciate the opportunity to have a choice to yet again weigh in on an issue that is very important to our society and our culture then, right?
Okay, so if we do this ban and vote on again, and the majority of people say we want legal abortion, are people going to say, we're going to do this again, and we're going to do it again?
I'm
and again?
I'm term limited to 8 years, so I can't speak for what's down the road. But I think
Right.
sending the question back to the people with clarifying language is what our job is. It is to let people weigh in on the issue. So just for my benefit, thank you for your concerns. But our job is to advocate for those issues that we think people sent us here, and to go back to the people and say, is this what you want? Is this what you meant? Is absolutely the role of government. So anyway, I appreciate your testimony and your time. Senator?
I'd just like to make a quick comment, respectfully point something out. I think, as the sponsor of Born Alive bill here in the Senate, and as the representatives have articulated, this particular piece of legislation, the intent of the legislators that are behind it, it's not an abortion regulation piece of legislation. It's not an abortion restriction piece of legislation. It's a piece of legislation that would say, if a child survives an abortion attempt, then that child deserves to have the same care of any other child of the same gestational age. So that's really what we're talking about here.
Thank you for the clarification, Senator. All right, any other questions? Seeing none, thank you for your time. Anyone else here in opposition? You can push the...
Hello, I'm Susan Renee Carter, and I'm from Columbia, Missouri. And I'm providing testimony in opposition of HB 1667. Since anti-abortion lobbyists and legislators are not medical experts, they should leave healthcare decisions to the medical professionals and the patient. While the facts do not show the risks stated by the lobbyists, they do induce fears of those seeking abortions. All of the threats and accusations have kept birthing people from getting health care they need, either by limiting care or frightening healthcare professionals out of providing care. The medical data that abortion is safe when it is provided in a safe medical environment, and the percentage of born alive incidents following abortion is close to nil if you consider that a lot of the figures that the legislators were giving you are related to babies with abnormalities. Yes, and the fact is that I know that this isn't really about abortion survivors. It's about interfering with the decisions that birthing people make about their own bodies with the guidance of skilled medical professionals. Interference is now healthcare is handled, has made healthcare more dangerous. More women are dying, and in states with bans, the numbers have soared. One study found that a number of people who died in Texas while pregnant during labor or shortly after giving birth surged by 60% after the state's strict abortion ban went into effect. Another study found that infant deaths increased by 13% because of the ban. So I feel like that if you're not a healthcare professional, that you need to stand down and get some additional information from them before you're making laws. Also to note that this is a federal law that covers this already. And
And so
Can you cite that federal law for us?
I cannot, no. You can Google it. It is a federal law. Along with the lack of experience, anti-abortion lobbyists are spreading propaganda about medication abortion. Medication abortion's serious complications rate is less than 0.5%.
Thank you for your testimony.
Anyway, thank you very much.
We're addressing the issue of healthcare, and so, I think this bill, to the senator's point and to the representative's point, is to try to address healthcare needs of somebody who's been born alive. They're laying there born alive, potentially needing healthcare. So I appreciate your concern for the healthcare of children. Thank you for your testimony.
Yes.
Any questions? Go ahead, Senator. Sorry.
Yep. I just wanted to help answer the question that the chair asked you.
Okay.
The federal law is the Born Alive Infants Protection Act of 2002, and then current state law, which is repealed in this bill, is on the first page line that's being strucken out. So there's both current state law and federal law.
Thank you. I appreciate it. I meant to write those down. I didn't. Thank you so much. Anything else?
No, I think we're good. That's it.
I just wanted to mention the federal law that has been brought up. I believe what you're referencing does establish in federal law that the child is a person. However, there is not a standard of care. There's not a requirement of care there. And so that is what we're attempting to do with this legislation. That's what the representatives are attempting to do.
I don't think that's whatever.
Well, we'll let
Oh,
you,
we've-
you can continue.
Thank you.
Okay.
Thank you, Madam Chair.
Next in opposition.
Hello, everyone. Doug Mann with Planned Parenthood Great Rivers Action. I'm not going to belabor the point. I think that the physicians and other people testifying did a great job. I do want to give some clarification, though. It was stated by one of the senators that this does not deal with abortion. This isn't an abortion bill. I will state that the title does say abortion with penalty provisions. So, by definition, abortion bill. And also, I believe that the care would be covered under EMTALA. So there's multiple pieces of law that would cover the care for these babies. So I'll take any questions.
Any questions for the witness? Senator Nicola.
Thanks for your testimony. If we already have a law that covers the health care of these babies, what's your concern with this bill?
My concern is that this bill would create issues with things such as palliative care, and it also includes an effective medical abortion ban. So while this bill, in its heart, is going to
explain that in the bill? Can you point to that
which
in the
part?
bill? About your abortion, the abortion part. You just
The abortion ban, I believe it's on I don't have the bill directly in front of me, but I believe it's on page 2 in the 30s lines. I want to say line 34, where it says the knowingly bring devices, medications, etc. That piece. So sorry, I don't have the bill directly.
No,
in
that's
front of me,
okay.
so
I got it
can't
now.
cite but yeah.
Yeah, I came in late too, so
I understand.
Yeah, just hearing some of the testimony. So, are you okay with saving babies? If a baby was born alive and is laying on the table after a botched abortion, are you okay with saving that baby?
Currently under the law.
No, I asked you, are you okay with that?
I'm okay with the proper care being given to that child, whether that is medical saving care or palliative care. But under this law,
So,
it
what is?
would
I'm
restrict
sorry
the
to
palliative
interrupt
care
you. What is
piece.
proper care? Going ahead and killing the baby?
I'm not a medical professional, and medical care is complex. So depending on the current situation,
So, life
it
or
could be
death is a
palliative
complex
care.
issue. Is that what you're saying? To either
It
save
could-
the baby, to keep a baby alive, or to go ahead and kill it when it is breathing and it's still alive on the table.
That's not what I'm saying, Senator. What I'm saying is
No,
that in certain
what I'm asking you the
situations-
question. If the baby's alive and still breathing, is alive on the table, are you saying proper medical care could either be killing the baby or saving the baby?
No, that's not what I'm saying.
What are you saying?
I'm saying that proper medical care could be life-saving care or it could be palliative care. It depends on the situation.
Okay, are you personally okay with the baby dying?
If they are not going to survive and they're given palliative care so that they're comforted, then that's the proper care that they should be given.
Okay, well, thank
and
you
that
for-
decision's up to the medical professional in the room, such as the physicians that testified earlier.
Yeah, thank you for your answers.
Yep.
Any other questions for the witness? All right, seeing none, thank you for your time. Next in opposition.
Good morning. Thank you so much for your time. I'm Amy Quo Hammerman. I volunteer as the state policy advocate for National Council of Jewish Women in St. Louis. Our mission is to improve the lives of women, children, and families. Instead of reiterating a lot of what's been already said, I would like to bring up that from our perspective, we are a faith-based organization, and religious liberty is very important to us. Part of that means that abortion is a part of the healthcare decisions we make with our medical providers, but also with clergy if we so choose. In our faith, abortion is not prohibited, and in some cases, our traditions teach that abortion may be necessary, either to protect the life of the mother or to provide compassionate care to an infant that is not going to survive. We have concerns that while there may be good intention behind this bill, it will cause a chilling effect regarding the very complicated decisions that need to be made by medical providers and of prospective parents. And we urge this body to defer to medical professionals in this regard. I will also say I understand the concern about what care might need to be provided to an infant in this frankly extremely rare case. However, infanticide is already illegal in Missouri, and medical professionals are already held to malpractice standards of care. So this bill feels more likely to cause harm and a chilling effect rather than produce the actual results that you seek. And I'm happy to take any questions.
Thank you. Any questions for the witness? Go ahead, Senator Hudson.
Thank you for being here. Thank you for your testimony. I am not trying, this is not a gotcha question. I just really want to know, have you read Missouri's infanticide statute recently?
I have not.
So the reason I bring that up is because in working on this legislation, I've read it. I would encourage you to look at that. There is some of the language in there that is very concerning to me. It's what I would call a carve out with regard to children that are born alive after there was an abortion attempt. So it's my view here, and you may see this differently based on your testimony, but it's my view here that a medical provider, if there is not established in statute a duty of care, that could leave that medical provider open to a lot of questions with regard to what they need to do. I think some of this could actually clarify a situation when you've got an individual that went in for a procedure, and that procedure was not successful as far as success would be determined in the individual's eyes. Would that leave the medical provider open to malpractice? Would that does the medical provider have a duty of care to the individual that went in for the procedure? Yes, absolutely. But shouldn't we establish in statute that the medical provider also has a duty of care to the individual that is born alive, even if there was an abortion attempt?
I can't speak to those details, sir. However, if there is a problem with the infanticide law, perhaps it would be more appropriate to adjust that carve-out that you're talking about rather than have this body with all due respect, not full of medical experts and physicians, make the decision about what the standard of care should be.
Certainly appreciate your perspective on that. My contention or my belief here would be that could the infanticide law be changed? Yes. Would that be enough? No, because that in itself would not establish the duty to care that we need to establish to make sure these children are taken care of and given what they need. But thank you for allowing me the opportunity to question you. Thank you, Madam Chair.
Any other questions for the witness? Seeing none, thank you for your time. Next in opposition.
Hello, my name is Craig Ward. I live in Ashland, Missouri, and I'm here to speak in opposition to House Bill 1667. I also speak to ask that you, to insist and demand that you respect the will of the people. This bill is just a small piece of the larger anti-abortion strategy to make abortion illegal and unavailable in all cases. Legal abortion is safe. Legal abortion is broadly supported. Missourians already voted to push politicians and government out of personal medical decision-making when a majority of us voted to legalize abortion and establish a right to reproductive freedom. Missourians already said no to abortion bans. I urge you to vote no on House Bill 1667. Thank you.
You see this as an abortion ban?
Did I say that it's an abortion ban?
Yeah.
I may have. I don't remember exactly what I had. I've considered not saying it, but as I read it, I see it as a disguised abortion ban. Dressed up as something to protect, babies born alive due to a failed abortion.
Are you okay with providing care to a child who's laying alive after a botched abortion?
As other witnesses have said, that type of care would depend on the condition of that infant.
Should there be an attempt to try to save the life of that child?
If that's appropriate. If the infant has been aborted because of known congenital deficiencies, genetic deficiencies, yes, some care, palliative care, as has been
I think that's included
explained.
and was alluded to by the House representative, so I appreciate your testimony. Thank you.
Thanks.
Any questions for the witness? Seeing none, thank you for your time. Anyone else here to testify in opposition?
Hello, my name is Catherine McLean, and I am here to speak in opposition because it is my belief that this seems like another way to restrict women's ability to make decisions. That's just my belief. You may have a lot of technical reasons why it isn't. But one reason I showed up here today is that I've been talking to people for at least 50 years, both as a social worker and as an ordained clergy person. And so I have strong feelings about when we're trying to restrict people's ability to make their own religious decisions, especially when it comes to their life and their death. I have seen babies born. It's the most awesome thing in the world. It's the biggest natural high you ever saw. And I have sat with mothers as a family planning coordinator who told me, I have 4 children. My husband's a drunk. I can't have any more. And all she needed was a way to take care of an early term pregnancy that she did not want or need. That was her decision. My faith as a United Methodist is that is a decision best made by women, their clergy people, and their doctors, and I urge you to quit playing with us. We have so many issues and problems, and why not put your energies more towards making life easier on people instead of dividing us over issues that we really don't need to be divided for. So thank you for the time. I wish I brought more facts and figures. I could certainly tell you many, many real life stories that I find more important than your fast speak and your political speak on how you're doing these bills. Thank you very much.
Thank you for your testimony. Okay. There's a lot of questions there too for me. But all right, next in opposition, we are going to have to wrap up. What? Yeah, so we have about We're going to hear from two more witnesses, and then we're going to have to pivot to our next bill. So 2 minutes,
Good morning.
please. Thank you.
My name's Melody Wilson, and I live in Columbia, Missouri, and I'm here to oppose House Bill 1667. My belief is that this bill was created by anti-abortion lobbyists and not medical experts. I believe that this language in the bill is intentionally disingenuous and serves to inflame an already emotionally charged political environment. There's disinformation about the abortion process, especially about medical abortions, which are safe, effective, and can be performed at home without pregnant women having to incur the cost and risk often involved with an in-clinic procedure. While I understand the born alive intent of the bill, I do believe, as many others have testified, that it is an end run around medical abortions, which have been deemed to be safe and effective. And this particular bill makes those medical abortions illegal and threatens providers and pregnant women with criminal and civil action. I believe this bill as written is disrespectful and offensive to Missouri voters, the majority of whom have already voted for safe and legal abortions. Missouri voters want and deserve a right to reproductive freedom. Thank you.
Any questions for the witness? Seeing none. Thank you. One more testimony in opposition.
Hi. Madam Chair, committee members, thanks for the opportunity to be here today. My name is Mallory Schwartz. I use she, her pronouns, and I'm here on behalf of Abortion Action Missouri. There's been a lot talked about today, and I want to take an opportunity to thank all the witnesses, especially the providers that shared their experiences, people sharing their personal experiences, and to address some of the questions you previously asked and some of the topics that were raised. A lot of folks generously came up here and talked about the difference between intent and impact. And I challenge that the intent, as has been stated, is to criminalize abortions and the people that have and seek them. There are criminal provisions in the bill, as has been noted, including a charge of homicide for providers that provide care. And this is all over situations that have been discussed at length and that do not represent the reality of medicine. This is not the medicine that is practiced. EMTALA, the Emergency Medical Treatment and Labor Act, requires care, appropriate care for those infants. And there are no other cases outside of abortion where federal law is expected to set medical standards. That is not the standard of care. Medical standards are set by physicians' associations and organizations. They're set by the doctors and experts who are qualified to set those standards and provide that care. Missouri politicians are not in a position to know better than those experts. And the risk falls on the patients in the end. The risk falls on the pregnant people in the end. The OBs did a great job of highlighting the harm of interfering in appropriate patient care. And this committee talked a lot today about gaps. This is not a gap that exists that needs to be addressed. This is not an example of the reality of medicine.
Thank you for your testimony. Any questions for the witness?
Mallory, thank you for being here, for all the witnesses that continue to join us in Jefferson City to share what I think you and I understand well, that reproductive health care is health care, and that this, again, is about, it's about abortion and criminalizing abortion. And one of the things that I, noticed, and, despite what anybody wants to say, this is absolutely about working to criminalize all abortion care. And one of the things I thought was interesting to note, even on the sponsor's binder, below the name of the bill is abortion, okay? Missourians voted for reproductive freedom. Missourians voted for reproductive freedom. And we're we're not going to stop, our side's not going to stop until people have access to health care. And I appreciate you all continuing to be relentless champions for this issue, and I appreciate all of the providers asking the state to let them stay in their lane and asking us as politicians to essentially stay in ours. I think that's very important, so thank you.
Thank you, I appreciate it. And I'd love to add that the chair asked whether the voters should have another opportunity, whether that's a fair thing to ask of them, whether clarifying language is appropriate to bring back to voters. And I bring back to you, or I ask back, like that clarifying language you're talking about was found to be intentionally misleading by the majority Republican courts in our state. So how clarifying is it?
I'm happy to discuss. I mean, we've got a couple of other bills that we're going to listen to, but I'm happy to discuss that issue with you because, I mean, obviously, there's a lot there, right, to say. But to send it back, like you guys get to vote on it. So I think that
We
is your
already
job.
voted on it.
Good.
Okay. Definitively.
And then I just have a brief question. So, you know, I've again, mom to 3 kids. I've had very complicated pregnancies. And you know, I just want to ask you, can you imagine having to pick up a phone when you're in a situation, whether it's in a delivery room, in a doctor's office, and having your provider pick up a phone to call and ask if they have permission to give you the care that you need? To pick up the phone of a politician to say, do I have permission to do this? Because that essentially is where the state is headed if this were to pass. So imagine if that was your situation and you had to pick up that phone.
Yeah, you know, I think about that every day. I'm 7 weeks out right now, and I'm fortunate to have a care team that I can trust, but we are putting doctors in the position where they can't trust themselves, and that means we're putting pregnant people in the position where they can't trust their care teams. And we saw not 2 weeks ago a woman in Florida who was forced into an unwanted C-section when they put a Zoom meeting in her lap while she was in labor, and let a judge dictate what her care should be. That is not the Missouri. That is not what any woman deserves, what any patient deserves, and that is not the Missouri where I would want to have my babies or raise my family.
I'm with you. Thank you.
Thank you.
Thank you for your testimony. I'm grateful that we all have the capacity as adults to be able to pick up the phone and ask for care, but the baby that's laying there after a botched abortion that has an opportunity to live doesn't have that leisure. So thank you for your testimony and appreciate your time.
Thank you. Again, that's not the
Representatives-
reality of care.
Representatives, if you would mind, just take a few minutes and wrap up.
Thank you, Madam Chair, members of the committee. We appreciate the time.
So,
Thank you,
Representative
Madam
Seitz?
Chair. The bill provides clarity as to what the provider's duty is if the baby survives the abortive attempt. And I appreciate the time. Thank you.
Thank you. All right, that wraps up House Committee Substitute for House Bills 1667 and 2294 with Representative Seitz. Thank you for your time. We will now move to House Committee Substitutes for House Bills 2033, 1608, 1672, and 1854. Representative Schmidt, good to see you. Begin when you're ready. Blood starts boiling. And Brad just sits there as cool as a cucumber.
Good morning, Madam Chair.
Good morning.
Thank you. Thank you, Madam Chair. Thank you, members of the committee, for the opportunity to discuss this very sensitive topic. For the record, my name is Melissa Schmidt, Representative District 141, which includes Laclede, Wright, Webster, Douglas County. I bring to you today House Bill 2033. This legislation seeks to remove the sunset from the SAFE Act as we work to secure the most effective and safe treatment for children diagnosed with gender dysphoria or gender confusion. The goal is simply that Missouri children who are working through gender dysphoria or gender confusion continue to have a safe and effective course of treatment as indicated when the SAFE Act first went into law in 2023. According to the Harvard Journal of Law and Public Policy statement made in regard to the topic of pediatric medical transition, the prohibition of pediatric medical transition is consistent with the watchful waiting approach to the care of pediatric gender dysphoric patient. It is based on data that most cases of gender dysphoria in children and adolescents resolve on their own by adulthood. Watchful waiting was an accepted method of treatment in the field of pediatric transgender medicine in the United States and Canada until 10 to 15 years ago. Variations of watchful waiting are once again a common form of treatment of pediatric gender dysphoria in much of Western Europe, as some countries have determined that the more aggressive medical interventions of puberty blockers, cross-sex hormones, and surgeries are not supported by scientific evidence. And these interventions are simply experimental and should only be employed in very exceptional circumstances. As we're observing other countries such as Sweden, Norway, and France move away from the attempt of childhood gender transition, we must be responsible to ensure we also are providing the best course of treatment. The UK also banned use of puberty blockers for minors, and the UK High Court upheld that ban in July of 24. In conjunction with that ruling, a thorough review of the England gender dysphoria treatment approach was conducted, and it included a harsh criticism of the United States approach for care for our children, as well as discussed lifelong effects, significant dangers of puberty blockers for minors. These countries recognized that their well-meaning approach in the beginning was based on insufficient evidence, and as they began seeing the growing evidence of harm and the growing rate of the attempt to detransition, they began to adjust course in the name of safe practices for children. We must not ignore the voices of those who have transitioned and who regret the decision. Many of these regrets are delayed, and that signifies the importance of the long-term studies such as the ones we're seeing. My position today is simply that we also can lead the way in care reform for Missouri kids. The Society of Evidence-Based Gender Medicine highlights that Denmark also made a resolute shift in how they treat youth presenting with gender dysphoric treatments with supportive counseling, prioritizing psychosocial support and non-invasive resolutions rather than puberty blockers, hormones, and surgery. We cannot ignore the results of those studies. We cannot ignore what other countries have reported and the changes they're making away from attempting to transition children. I honestly could discuss this topic all day, and I know we have other things that we must consider. I have lots of information here. I'm happy to refer to my co-sponsor, and I'm happy to take questions. But what I think we must also not ignore is the conversation around suicide, and I would like to talk about it for just a moment if the chair will allow, and then I will tag over to Representative Seitz. We must not ignore the cry and threat of suicide, and we must not ignore the statistics after transition. We must treat the threat of suicide effectively and prioritize the mental health condition driving the desire to commit suicide with supportive counseling. It is real psychological pain that drives someone to state they are considering suicide, and we must look at all underlying causes. There is no medical solid evidence that transgender medical treatments in children reduce the psychological distress and mental health associated with true gender dysphoria. There is, however, solid evidence the harm to the mental health of the patient. Sweden conducted a 30-year outcome study post-transition, and the result indicated 10 to 15 years after transition, the attempt and completion of suicide rose to almost 20 times higher than that of the general population. The solution is not transition for our children. The solution is solid support for the family, solid psychosocial counseling for the child, and helping them work through their confusion. And with that, I will pass to Representative Seitz.
Thank you. For the record, I am State Representative Brian Seitz. Aside from removing the sunset, this legislation provides an off-ramp for children being given drugs in an attempt to change their physical appearance by stopping or masking inherited genetic characteristics. No treatment can change a person's genetic composition and no studies have demonstrated long-term benefits. My goal, our goal, is to protect children. Let adults make adult decisions. Thank you, Madam Chair. Thank you, committee.
Thank you. Any questions for the representatives?
Yeah.
Just one at a time.
Yeah. I just want to thank both of you for bringing this piece of legislation up. I think it's common sense to help protect our children. So thank you very much for the work that you've done on this, and I look forward to seeing this passed. Thank you.
All right, thank you. We're going to go to, we have the room until 10 o'clock. So we are going to really hustle through this. So we're going to limit testimony to 1 minute. Those in favor, come forward.
Can we alternate just because, I mean,
Yeah,
if we have
well,
five.
that's-
Okay,
that-
thank you.
Good morning, Timothy Faber with Issachar LLC. With 1 minute, I'm going to leave a lot of these here, but I do want to remind you to read the Nuremberg Code. And if we remove the sunset clause on this previously passed bill, we, as Missourians, will be violating the Nuremberg Code.
Thank you. First testimony in opposition. You can also use, if you're on the side of the room, you can use that just for future reference. You don't. Also,
there.
make sure that
Oh.
you leave a witness form on the table.
Okay, gotcha. I have a minute?
Yep.
Okay. My name is Nathaniel. I'm 26 years old. I'm originally from Fredericksburg, Virginia. I'm a medical student in Kansas City now. This is like really intense energy in here. I don't know how you guys do this every day. But
You're welcome to come back.
I just came to share my story. So I was born female. I transitioned to male when I was 16 years old. I tell my story, and it's pretty anticlimactic. I grew up, my dad's a computer guy, and my mom's an administrative assistant. And I grew up in a town that was pretty neutral. I mean, we didn't really go to church, but we also weren't against church, But yeah, I started testosterone. It was a pretty long process, I guess. I had kind of talked to my parents about things and my friends about things since I was 15 years old, 14 years old, of just like navigating, just being interested in girls, I guess. And then I got to the point of wanting to start testosterone, and it was about 9 months or so that I had to go through different psych screenings. My parents had to get interviewed for psych screenings and such. But yeah, I'm in medical school, I'm married, I've been on testosterone for 10 years, and I'm incredibly happy. So, I mean, I'm just a lived experience, and I would love to, get to know you guys and talk more about this. So.
All right, thank you. I'm
Yeah.
sure the representatives would be happy to do that, and any member of our committee as well. So
All right,
thank you
thanks.
for your testimony. Next, in favor? 1 minute.
Good morning, Madam Chair and members of the committee. I'm Dr. Guillermo Villatrueva for the Missouri Catholic Conference, and we would like to go on the record in support of the House Committee substitute for House Bills 2033, 1608, 1672, and 1854. For the sake of brevity, we'll just mention that we support this great bill because it would ensure that minors continue to be protected from life-altering cross-sex hormones and puberty-blocking drugs that could lead to irreversible consequences such as infertility and lifelong dependence on costly hormone therapies with significant side effects. So we thank you for listening to these bills, and we urge you to vote to pass on them. Thank you.
Thank you. Next in opposition, rotating to opposition. For the benefit of everybody here who has come to testify, we would just want to make a note and let you know that you can leave your witness form on the table and also any written testimony that you want, and it will be distributed to the committee afterwards. Begin when you're ready.
Okay, great. Hi, my name is Marique Jensen, and I have been working with LGBT youth for the past 30 years. I have helped run multiple LGBT youth programs across St. Louis, Missouri. Currently, I run Transformations, which is a trans youth group supporting trans young people for the past 10 years in Kansas City, Missouri. I have to say that the statistics that you're saying about trans youth regretting transitioning are wild and crazy. That is not the reality of what we see with trans youth. I myself am a trans woman. I work with trans people all the time. That is not what we're seeing. This is based on fear. This is based off a narrative that trans people are somehow wrong, when that actually is not based on statistics at all. The only suicide attempts that happen are actually the actual danger we go through in society. It's not based off of what we're experiencing because of regretting detransitioning. Most trans youth do not actually start medical care they actually do not go through that. They certainly don't have surgeries. So the very reality of even how this bill is written is perpetuating a narrative and a false idea about how trans youth experience their realities.
Thank you. Make sure you leave your witness form on the
Absolutely.
table. Appreciate your
Thank
testimony. Next in favor.
Madam Chair, members of the committee, Tim Schultz with the First Amendment Partnership in Washington, D.C. 5 things that have happened since you passed this law in 2023. First, already mentioned by the sponsor, the CAS review in the United Kingdom. It's changed the policies in the United Kingdom, in Denmark, and in Sweden in a direction consistent with this legislation. Second, the Alabama lawsuit over a similar bill that was ultimately dropped by the plaintiffs after a lot of embarrassing things that came out in discovery, again, in ways that support what you did in 2023. Third, the Schmidt case in front of the United States Supreme Court, which would mean this legislation is constitutional. You also had a concession by the ACLU's star attorney that the suicidality claim is a myth. Fourth, the backtracking of major medical associations in their support for so-called gender-affirming care or sex rejection procedures, including the American Society for Plastic Surgeons and the American Medical Association. And finally, just last month, a $2 million verdict in the Fox Varian case in New York State, which is, again, blew America in a detransitioner case. I think we're going to see hundreds and unfortunately maybe thousands of more because of the medical malpractice in this space. So 5 developments.
Thank you for your testimony. Make sure you leave your witness form on the table. Next in opposition. And this will be our last testimony.
With thanks to the committee, my name is Heather Welter McCabe. I'm a lawyer who's an associate professor of law, and I'm a social worker who's worked at a pediatric tertiary care hospital for children for over a decade. And I'm here today to speak in opposition to removing the sunset provision on banning access to gender-affirming care for minors. I believe we're likely all invested in this issue for the same reason. We care about kids. And the ban on gender-affirming care takes away one tool from parents in consultation with a medical provider to help their child when that child is transgender or otherwise needs gender-affirming care. My research looks at how laws either promote or mitigate stigma. To be clear, much of the harm to gender diverse youth comes from stigma and discrimination. Earlier testimony about increased suicidal ideation for youth was shocking and painful, and laws which even unintentionally promote stigma to a group already experiencing significant mental health harm should, in my opinion, be re-examined. Missouri already has laws in place for challenging inappropriate medical care. Standards of care already exist. I respectfully ask the committee to vote no to ending the sunset on gender-affirming care. Thank you.
Thank you for your testimony.
I just want to say, I know that this hearing was really rushed, and I think there's a lot of folks who didn't get to testify. I just want to say personally, whether you're in support or opposition, you're welcome to come to my office and talk to me or my staff. I'd love to hear from you, and thank you for being part of the process.
Thank you, Madam Chair. I wanted to echo that. This is a very intense hearing. You're correct in saying that. I'm unfortunate that we didn't get to hear from the many Missourians who came here to share their stories and their testimony. And if I can get a show of hands, please, if anybody who's planning to testify in opposition, can you raise your hand? And again, Madam Chair, I ask that we give these folks the dignity and the respect of their time when they come here, that we recognize that these hearings are going to take time, and I think it is incumbent on us to use our time to listen to folks who come here. So I ask that all those folks, please, that wanted to share their stories with us, please provide in writing to all members of this committee what you wanted us to know, and open door as well to my office to share your stories. And I hope that we can take those stories and share them when we debate this legislation on the Senate floor. Thank you.
So as rightfully said, that is what the senators should do, is open up their offices when committees' rooms are no longer available. So we looked into having the hearing continue for later in the day. There's just no availability. So it is important that you have your voice heard. Everybody, and there is not a committee member or the representatives that are unwilling to have you listen and listen to your concerns that you have. So feel free to continue to do that. That's why we said leave a witness form. If you haven't had an opportunity to testify, leave a witness form on the table. And if you have any written testimony, feel free to leave that. And then also go talk to your senator who's up here in the committee.
Madam Chairman, morning. Do you know if I submitted mine online on the Senate portal?
Thank you. Representative, sorry.
Thank you.